I'll be sharing some of the intraoperative challenges that have occurred during or handling the Descemet's membrane, dealing with the dancing Descemet's as I've labeled it. We do receive research grant support from Alcon Laboratories. So this was a 67-year-old female, a grade 3+ cataract. The left eye cataract surgery flax with Vivity toric was done 3 weeks ago, very happy, and therefore was planned for a right eye flax Vivity toric in the second eye. The cataract was relatively dense, but nothing very unusual about it. And we went ahead with the flax firing, the capsulorhexis being done, and we like to do the main incision, and we like to do a trapezoidal incision. Now notice this bubble that has come up during the firing. Now it's sometimes the bubbles, they do come and they get released into the anterior chamber. This at that point of time was noticed that this bubble has actually not disappeared or has not gone off into the anterior chamber. Even before starting, as you can see this bubble is there, which means the air has probably, or the gas has probably, the femtosecond has sort of caused a little bit of stromal separation in this area. We have seen this before, and we know that once we decompress the eye, this disappears and everything goes off well, which fortunately also happened in this case. As soon as the incision was opened, we made sure that the Descemet's is actually stuck to the incision back to the endothelium, and the rest of the surgery fortunately went off very well. And the IOL implantation, you can see here this slight flap margin of the Descemet's, but that's something that all of us see very, very often. At the end of cataract surgery, around the incisions, a slight Descemet's flap that is there. But the rest, everything looks absolutely fine. The IOL is being dialed into position, and nothing unusual was noticed at this point of time. Retrospectively, this is something, this kind of area or this kind of shadow was something that we did not expect. But you can notice here this free movement of the flap, which meant to me that this Descemet's is just a little detached here at the incision site. Rest of it looks absolutely okay and perfect. So I did not expect anything to be there on the next day. The next day, the patient was not smiling as much, but we expect that in the second eye, they always feel more, so I was still not worried. But when I looked at the slit lamp, I saw this sectoral temporal corneal edema. And then I started thinking back, why is this patient likely to have this edema in the sectoral area? So we investigated further. We did the anterior segment OCT passing through the incision, and you can notice here that through the incision, this is the incision, the Descemet's is attached here, but there is a pocket of fluid that is collected between the Descemet's and the endothelium in this area. So at no point there is a free floating Descemet's flap, but there is an intrastromal fluid collected between the Descemet's and the endothelium. And the pachymetry also shows sectoral thickening of the or sectoral increase in the corneal thickness. The rest of the cornea is absolutely normal and of normal pachymetry. So I thought this is just some fluid collection. Should settle down, the IOP will build up, and everything should be okay, since the rest of the Descemet's is attached and the patient doesn't have fuchs or anything. So we decided to wait for 2 weeks. At 2 weeks, unfortunately, there was no improvement at all. In fact, the pachymetry started increasing in the area of the temporal Descemet's detachment, and now it started to become a little worrisome. We did the anterior segment OCT again, and it showed the same thing, that the Descemet's is attached through the incision, but there is a pocket of fluid collected between the Descemet's and the endothelium. The rest of the cornea, as you can see, the Descemet's gets attached, and the rest of the corneal thickness is perfectly fine. So having learned from our cornea colleagues, it's best to put some tamponade inside the eye to make sure that this Descemet sticks back to the endothelium. The first thing that I wanted to do was to open up the main incision so that whatever fluid is trapped between this incision site and this area should collapse and come out. So that's what I'm doing. First, I'm opening up that flax incision, and you could see that collapse occurring. So fluid from the anterior chamber, as well as I hoped from the gap between the pocket of the Descemet's detachment has also come up. And then I use a 30 gauge needle and approach it from the opposite side. So I'm not using any of the side ports or the main port. So I use a 30 gauge needle and approach it from the opposite side and inject air, no gas, because this was a relatively fresh Descemet's detachment. And the aim is to try and fill up this entire anterior chamber with air as much as possible. So you want to go almost up to the limbus, and when there's a graft, you would see what they call as a double ring sign. Here, obviously, you won't see that. As soon as I brought it out, there was some collapse of the air, so I went ahead and injected it again and made sure that it's a full chamber of air injection. So the next day, the half of the air bubble is there. There is some corneal edema, obviously, because it's a second surgery, just 2 weeks down the line. The Descemet's has started to show signs of attachment. The fluid pocket has reduced drastically, significantly. There's an overall increase in the pachymetry because of the air and second surgical trauma. This is 4 weeks post-op of the air injection. You can notice the cornea is absolutely cleared off. There's no sign on gross slit lamp examination of anything else. If you do make a slit and see, you will see that area where the Descemet's flap was there. There is a slight scarring there, but it's off the visual axis and the patient is very happy. The anterior segment OCT shows a uniform pachymetry and a well-sealed cornea. Second case of a 72-year-old female, grade 2 cataract, planned for phaco with monofocal toric IOL. Nothing absolutely unusual all through the case. Everything went off very smoothly, and we are doing the irrigation aspiration, where I started to notice something here in the area of my aspiration probe. So keep noticing here this sort of reflex. Initially, I felt must be some viscose stuck on the cornea, and I went ahead nonchalantly going ahead with that. Now, having done the cortex removal, I actually realized that this was not cortex, this was not viscoelastic, this was actually a Descemet's flap which has got, Descemet's which has detached. So this is the margin of the Descemet's detachment, and this is the flap which has got detached from here and got everted on this side. So now is a situation where it's a little bit tricky. So first I want to make sure that this is attached on the other side, which fortunately it was. It was just detached from one side. So I thought I'll go ahead first, let me implant the IOL and then think about what to do with this Descemet's membrane. And we made sure that we did a good IOL implantation in the bag. And because I felt that there is good attachment on one side, if I just reposition this Descemet's with the IOP building up post-operatively, this Descemet's should attach on its own and nothing should happen. So I went ahead, made sure during IOL implantation and rotation that the aspiration port is directed very much away from the area of the Descemet's detachment, and it looks right now very well attached at the end. The flap and everything is perfectly attached, and I hoped it will settle down nicely in 2-3 days time. Unfortunately, it didn't. This was post-op day 1. The corneal edema is there, and there is a sectoral Descemet's detachment. There's significant increase in the pachymetry. At 1 week, it's localized now to only the patch of the area where the Descemet's was there, but still there is some detachment of the Descemet's with the flap being not opposed very well at the area, and the pachymetry is getting localized, the thickening is getting localized. So having waited for 3 weeks, we decided we need to do something about it, and this is the area of the Descemet's flap. So I'm going right below it and making sure that I inject an air bubble from below it so that it gets tamponaded quickly, and then making sure that the rest of the entire anterior chamber is filled with air. Fortunately, 2 months post-operatively, it's recovered well. You can see a slight scarring in the area of the Descemet's flap, but the patient is quite happy and quite accepting, and fortunately, the global pachymetry map is also symmetrical now all across. And this is the last patient, planned for flax with monofocal toric. Again, another similar situation noted intraoperatively. probably the chopper in the initial, when you're learning, if you're not careful in a shallow chamber, sometimes you can just scratch the endothelium with your chopper, which unfortunately led to this Descemet's detachment. So having learned from the first case, I knew that I don't want to leave this flap as it is, because I had to inject air for that one post-operatively. So having implanted the IOL and having made sure that the flap is attached now, I'm going ahead and forming the chamber and then going to inject air on table for this eye, having made sure that the flap is first everted, and then injecting air all across through the side ports to make sure that the chamber is formed. The patient fortunately did very well. There was very minimal corneal edema on the next day. The Descemet's was attached, and therefore I was happy that this corneal thickness, which has increased, is going to come down nicely, and the cornea cleared off very well. So I think the Descemet's can, we need to be very careful at each and every step that we do in cataract surgery. Your movements with your left hand, your chopper, your IA probe, injection of viscoelastic. Early detection is of paramount importance, and if you detect it on table, it's best to treat it on table, which I realized with my 2 cases. And whenever in doubt, AIOC2024 always comes to the rescue. So thank you so much for the patient listening.
Thank you.